I am Yoshiki Wada. I work in the Digestive Disease Center, Showa University, Northern Yokohama Hospital in Japan. I will start my presentation entitled as Vascular Features of Colorectal Mucosa and Neoplasia with Endocytoscopic-Narrow Band Imaging.
Narrow band imaging enhances the surface microvasculature of the gastrointestinal tract. The endocytoscopy system is a recent developed technique. Recent pilot studies have suggested the potential of endocytoscopy to enable microscopic observation at the cellular level in vivo and to diagnose malignant lesions in esophagus and colon. The aim of this study was to evaluate the vessel of colorectal lesions with endocytoscopic narrowband imaging in vivo. This is an integrated type endocytoscope XCF-Q260 EC1 Olympus Tokyo. With this equipment, we can observe the lesion in an ordinary image with magnification up to 80 times and with ultra-magnified image of 450 times. The subject was compound of 86 consecutive patients. A total of 94 lesions were evaluated. In 11 randomly selected cases, the adjacent mucosa of the lesions that looked normal by conventional endoscopy was analyzed. The picture of endocytoscope was regular quadrilateral rather than fissure lens. The length of each side was 426 micrometer and established as a standard. The diameter of vessels in colorectal mucosa or lesions was measured and calculated. We will show you typical cases. This is a protruded adenoma, 10 mm in diameter. NBI magnifying endoscopy shows network vascular pattern and type 3L pit pattern. We first observe magnifying NBI and chromoendoscopy. Then we switch to the endocytoscopic mode by a single touch on the button. We can see a regular lumen, and then by changing in NBI, we can observe the vessels of the regions. We can observe the regular lumen, and then by changing in NBI, adenomatous vessels thickness was almost uniform and as regular pitted surroundings. We can also observe the flow of red blood cells. Massively submucosal invasive cancer, 25 mm in diameter. This is type 5N pit pattern and irregular pattern in magnifying NBI. In endocytoscopic NBI, gland formation was unclear. The vascular feature of massively submucosal invasive cancer was unusually large in caliber and with network interruption and tortuosity. As for maximum diameter, neoplastic vessels were larger than normal vessels. Submucosal massively cancerous vessels were also larger than the other neoplastic vessel types. To conclude my presentation, endocytoscopic NBI allows a real-time observation of colorectal vessels. It was possible to distinguish neoplastic from non-neoplastic lesions and massively submucosal invasive cancer from adenoma, slightly submucosal invasive cancer. EC system does not only provide real-time histological images in vivo, but also illustrates the vascular features of colorectal mucosa and neoplasia with NBI system.